Good morning, all. I'm Leopold Chenche. I'm an assistant professor at the London School of Hygiene and Tropical Medicine, based at the MRC unit in the Gambia. I'd also like to thank the organizer of this conference to attract me to join the Pathogenesis group and to give me the opportunity to share some slides about the host immunity and bacterial diversity influences of post-TB lung disease pathogenesis and host-directed therapeutics. I hope by the end of this talk, I will convince you that it's good to account for this host diversity and pathogen diversity. Well, TB is caused by a group of closely related mycobacteria called Mycobacterial tuberculosis lineages. Among the pathogens that cause disease in humans, we count 10 different lineages, and we're still counting since our whole genome sequencing increased. Some lineages have evolved, adapt the ability to spread around the world, like lineage 4 and lineage 2. But because of migration, in most parts of the world, you have more than one lineage causing disease. On top of this pathogen diversity, you also have host diversity. For example, this study showing the human genetic diversity within Africa really show that ethnic groups have different genetic features across Africa. Despite this diversity, for drug-susceptible TB, we still use the same 6-month treatment regimen across the continent. And I've been studying differences in strain diversity for a very long time. All the studies I've published. For the interest of time, I summarize most of the findings in this diagram. At the onset of disease, you don't find many differences in the clinical feature. However, when you measure the cytokine and gene expression, in M. africana infected patient, in the dotted line, you have high level of cytokine associated with poor control of TB at the onset of disease. But the difference really emerged following treatment, where M. tuberculosis in the bowl line go on to recover clinically with better body mass index recovery. The chest score goes down, and also they have high level of cytokine associated with good treatment response to IL-15. Whereas in M. africana infected patients, they don't recover clinically as well, but also they have high level of cytokine that are associated with poor treatment outcome. There have been other studies showing that the rate of sputum conversion is slower in the M. africana infected patient. You agree with me that when you regard to post-TB lung disease, these two group of people will be differently predisposed to post-TB lung disease. And currently, we're carrying out study to look at that after treatment. For this study, the investigation stopped at 6 months. However, this differential pattern of cytokine expression prompted me to think that host-directed therapeutic will be a very good approach to support the treatment. So host-directed therapeutic adjunctive treatment approach that aim to stimulate the host's ability to kill the bacteria, but also to reduce immunopathology associated with tuberculosis. The problem here is that despite complete treatment, almost, as we know, we heard 50% of patients have loss of lung function, but also post-TB patients have 3 to 4-fold likelihood of the mortality compared to the normal population. And there are different host-directed therapeutic approach being investigated. However, in the context of this talk, I will highlight two: the use of N-acetylcysteine, which is a food supplement. You can get it off the shelf, used for different conditions as decongestants. Now can directly target the bacteria, but also get transformed into glutathione, which is the active form, and act as an anti-inflammatory. I also highlight study that we have done on tyrosine kinase inhibitor. The problem is that tuberculosis immune profile is very complex. TB patients end up with the disease out of hyperinflammation. Others may end up with disease with hyperinflammation, but when this patient presents at the clinic, you cannot guess which profile they have. So you agree with me that if somebody were having a hyperinflammation profile, they will benefit more from host-directed therapeutic that is immunoregulatory, such as N-acetylcysteine, whereas those that have a hyperinflammation profile will benefit more from immunostimulatory host-directed therapeutics, such as interferon gamma. Regard to N-acetylcysteine, Most of the previous studies have been using different concentrations, so 400 to 600 milligrams daily. Other studies use up to 1,200 milligrams and concluded that further dose optimization is needed. And most of these studies have as endpoint the sputum convention, and they not really managed to hit this target. And there were a lot of heterogeneity in these different studies. One of the first studies in Africa that had improvement of lung function as endpoint was done in Tanzania. And you can see here, despite the fact that NAC improved the level of glutathione compared to the control, this was not near the healthy control level. And also the study showed that NAC managed to reduce the level of pro-inflammatory cytokines such as TNF-alpha, but it did not affect anti-inflammatory cytokines such as IL-10. Although also NAC improved the lung capacity following treatment, there were really a lot of heterogeneity. At this point, you may ask if we want to investigate the impact of host and pathogen diversity, how are we going to do that? Well, for the past few years, we grant from the NIH and the Royal Society, my group and I have been really thinking about this, and we came up with this approach. So first of all, we got clinical strains of TB, transformed them by a certain plasmid so that they can emit light where they grow, and we target monocytes. So we isolate monocytes using this big approach. And having this platform, we can infect monocytes of TB patients with TB pathogen that are similar to what caused their disease. And in the plate format, we can do that in the presence or absence of drug. I use a plate reader to actually monitor the bacterial growth intracellularly. We also build an in-house application that enables us to see the bacteria as they grow daily. So we do a 7-day infection assay. And you can see here, in the presence of the bacteria with or without the drug, the green line is without the drug. You can see there are some participants depicted by the ID there that are non-responder. In the presence of the drug, the bacteria actually grow. But there are others that are responder. In the presence of the drug, the bacteria grow less. And using this type of assay, you can actually start to predict people's profile. And using the assay now, I'm involved in this clinical trial of NAC that is going on in 3 different countries, but Wallis that will be speaking tomorrow is a PI. One feature that I want to highlight here that we use up to 1,800 milligrams, and the primary endpoint is spirometry. So what we have been doing already was to look at the direct effect of NAC on this pathogen, and it can show you for at least these 2 that the IC50 are different, just to bear that in mind. So I'll be having blood sample, infect them at different time points in the presence of the bacteria and the drug in order to anticipate who might be responder or no responder. You can also get sample from this and measure different cytokines that you use to correlate with the lung function outcome as a biomarker. Well, in conclusion, I hope I'll be able to convince you that it's important to look at the pathogen diversity and the host diversity because they do affect post-TB lung disease. We also need biomarker to be able to evaluate these host-directed therapeutics. And I think clinical trials should account for this patient and bacterial profile because maybe the same drug combination will not work for everyone. I would like to thank the member of my team that supported me to deliver on this work, and also my funder, including Life Act UK, the CAN African Network, the Royal Society, and the NIH. Thank you very much.